All
Thank
right.
you for joining us again for the second day. We already had excellent discussions yesterday. Really looking forward to today's sessions on health workforce, on migrant children, and then some innovations. Remember, we're in problem-solving mode. That's our motto for this conference. And this afternoon, we'll then also end off with the research abstracts where we have fantastic contributions from people. So thank you for joining us again. And over to you, Haroon, for this next session. Thank you.
Thanks, Uta. So good morning, everybody. My name is Haroon Saloojee, and I'm going to be facilitating both this session and the next session. So for the first session, I think the conference asked us to make a shift. It's a shift from crisis mode to solution mode. And we're talking about child health. And so this session, to my mind, is the heart of that shift, because we're talking about strengthening South Africa's child health workforce so that the future for children is truly healthier than the present. Because if we strip everything away, guidelines, equipment, budgets, policies, you are left with one truth, and that is that the workforce is the system. If the people caring for children are well-trained, confident, competent, the health system works. If they are not, then the whole entire system struggles, no matter how much we invest elsewhere. I can offer you some very sobering facts. Just yesterday, I read that we have a shortage of 150,000 nurses in South Africa. So when you look at a statistic like that, often we just glaze over it. It's just a number. I often wonder where those kind of numbers come from. What is the 150,000 based on something? Is it in comparison to international statistics? Is it based on the Purcell system, on how do the numbers come through? But the truth is, wherever you go around in our country, you hear we've got staff shortages, and or often, as you said, we're short-staffed. And so today really is a focus on this. Now, it's not the most exciting topic for many people. Even as the organizing committee, we argued whether something like health workforce is pertinent to the conference. And the main reason for that is we all feel so hopeless. What does one do about the workforce? I mean, we know we've got shortages in so many cadres of child health workforce, but can we do anything about it? And I think we often shrug our shoulders and say, no, there's nothing we can do about it. So why even bother talking about it? And I think that's what today's session is different. We're hoping that at the end of the session, we do have a sense of, one, what the issue is, and more importantly, what we can do about it. So we have three speakers for today, and I'm going to introduce them individually when they start. But very briefly, what we have is, firstly, we've got Professor Lesley Bamford, and she's from the National Department of Health. And she'll outline the current gaps, the current state of the child health workforce in South Africa. And she'll ground us in the realities and the gaps. Our second speaker will be Professor Robert Armstrong. He's the Professor Emeritus at the Aga Khan University, and also he's based in Vancouver at the University of British Columbia. And he's going to share global insights on achieving national models that drive policy and practice, and lessons that we can adapt locally. And then our final speaker is myself, and I'm going to be talking about competency-based approaches to training and education, which I believe is critical for preparing practitioners for the evolving needs of children. All right, so that's a little bit of background of what today is all about. So I've said a little bit about Dr. Bamford. She's actually Professor Lesley Bamford. And I think most of us know Lesley because she's been in this forum at our conferences, but also with her many other work. She's been a core part of the National Health Department's Child Health Unit. And her work involves focusing on child, youth, and school health. She's a pediatrician, but she's also had training in public health. And she really is one of the key players in shaping our national child health policies. She's had interest in the vaccination program. She's had interest in childhood interventions. So Lesley, thank you very much for joining us. Prof Bamford has got a commitment at 10:30, so won't be able to stay with us for the whole session. But please go ahead and we look forward to your presentation, Lesley.
So thank you very much for that introduction. Can I just confirm that you can hear me and see the slides?
Yes, Lesley, we can hear you very well and we see the slides.
Okay, so perfect. So thank you very much for this opportunity. I have been asked to talk about issues related to the child health workforce in South Africa, looking at the structure, the capacity, the challenge, and some solutions. Just a disclaimer, I think this is not an area that I really consider myself to be an expert in, but in a sense, maybe that's the most important thing about this talk, that because it highlights the fact that I think as a maternal and child health community, we have not really paid sufficient attention to issues around human resources and our workforce in a very systematic way. And maybe that is a gap and hopefully something that we can apply our minds to as to who should be taking the lead in this area. What are the critical areas and gaps and some of the solutions that we as a child health community should be coming up with and advocating for. So just a bit of an overview and background. To a large extent, pulling from the National Departments of Health's Human Resources Strategy, which is a very impressive document, unfortunately, which does lay out a vision and ambitious plans around human resource development. So a strong strategy, but one that is challenging to implement and to realize in full. So I think we know that our child health care services in South Africa are delivered through a multi-tiered system, which obviously needs to cover the full continuum of care, from household through primary health care and our hospital-based services, both district, regional, central, and quaternary services. And so, of course, the workforce consists of many different cadres, and you can see some of them written there on the slide. And this, of course, does require integration across the levels of care to ensure that we do have a seamless continuity of our services across these various levels. And I think that is one of the challenges that we do continue to face. So pockets of excellence, each cadre working to develop their human resources, but not necessarily, we do not necessarily have a clear view and clear ways of ensuring continuity across all the levels. So let's start with community-based services. This is a topic that we have discussed many times over the years at this conference. We know that we have ward-based primary health outreach teams, that each team should be led by a professional nurse, ideally, or a enrolled a staff nurse, and should be made up of a team of community health workers who undertake home visits and play a critical role in linking families to clinics and other services. But we know that we have had a very uneven rollout across the provinces. This is an old figure from 2017 of 42% coverage. We know that we have about 40,000 active community healthcare workers, but that is probably only about a third of what we would need to have full coverage of community health care workers. Over the years, we have also often flagged the issue that our community healthcare workers have limited focus on maternal and child health. I think some progress has been made thanks to the good work done by some of our partners, particularly Grow Great, who through targeted support have, at least in some parts of the country, increase the focus on maternal and child health. So there are good lessons to be learned, but there certainly is still a lot of work to be done to ensure that community healthcare workers really are playing the role that they can potentially play in promoting maternal and child health. Of course, we also know that there are many issues related to efficient and effective community healthcare programs, limited resources, inconsistent training, unclear pathways, as well as weak supervision. We do also, poor linkage to primary healthcare facilities has historically been an issue, but I think we are seeing that our WBOTs are embedded in our healthcare system. And I think some progress is being made with regards to ensuring those linkages to the clinics. Now, we know that introduction of WBOTs was one of the 3 streams of primary healthcare re-engineering, with the other 2 being the district clinical specialist teams, as well as implementation of school health services. And again, I think this audience is very familiar with our DCSTs, both what they are expected to do through providing clinical governance, mentorship, and quality assurance for maternal, neonatal, and child health services. And we know that when the district clinical specialist teams were introduced, there was this ambition to have quite a large team in each district, each of the 52 districts across the country. Initially, we had a good coverage, and I think there were golden years, certainly from us in the National Department of Health, when for the first time we really had a workforce at district level who we could communicate to. We have always had good communication channels to our nurses working in our primary healthcare facilities, but the communication channels for doctors, particularly and services provided in our hospitals, are less clear. And the DCSTs played and continue to play, where they are in place, an incredibly useful role in bridging that gap. And in the years when we had almost full complement of DCSTs, I think we can see that we made a lot of progress in terms of reducing our maternal and child mortality rates. Unfortunately, probably we were somewhat overambitious. The team, as outlined on the slide, is very expensive and is probably not justifiable given our current resources in all districts in the country. Certainly, it's fully justifiable in our large districts, particularly our metros. But I think largely as a result of the costs associated with DCSTs in a number of provinces, as we know, these have been dismantled. So I'm spending a little bit of time on this because I think from an advocacy point of view, reintroduction or reinvigoration of the DCSTs, maybe with more of an emphasis on affordability, really is something that we as a child health community should be advocating for. Okay, so we've looked at community health workers, something about DCSTs. Then, of course, to come to what really is the backbone of our primary health care services, namely our nurses. There are some figures here. So we have about 270,000 nurses in South Africa. We know that we do face a aging workforce in terms of our nurses. especially our nurses working at primary health care. And there are some concerns that we are not generating or graduating enough nurses overall to replace our nurses who are either aging out, immigrating, moving into the private sector, so that we do remain with a vacancy rate of around 15 to 20%. We also have some particular concerns or shortages of nurses, of midwives, and of specialized neonatal and pediatric nurses. So again, maybe just to pick that up as one of the issues that we should be advocating for in a more systematic way. We continually expect more of our nurses at primary healthcare level, but we are not increasing the number who are available to perform the many tasks that we assign to nurses. Okay, so definitely the backbone of our primary healthcare services. Then if we move on to our hospital services, and I think there we have even less information and sense of exactly what our child health workforce looks like within our hospitals. We know that we obviously have medical officers, we have family physicians, we have pediatricians, and we have our nurses, as well as our allied professionals. And we do have an expectation that these different cadres will work together as a multidisciplinary team. And of course, as we move towards national health insurance, it is going to become even more important that the different cadres work together in multidisciplinary teams with well-defined roles and responsibility. We also have clinical associates who work under physician supervision with the aim of improving access to and reducing the workload in underserved area. Child health, maternal and child health are one of the areas that clinical associates are supposed to be working in. But I must say, I have actually not seen or heard, there is very little anecdotal or systematic information that I'm aware of regarding the role that clinical associates play in supporting maternal and child health services in our underserved areas. So what about pediatricians? We know that our pediatricians are the best estimate is that we have approximately 1,000 pediatricians in the country, but we know that they are extremely poorly distributed across the country. So with huge inequities, both between the public and private sector, as well as between geographic distribution. So I know we were told that Limpopo now has 7 pediatricians. I think that's right in the public sector. That is a tiny number for the huge population. However, it is, I can remember when there was only 1, and when we celebrated the fact that Limpopo received their second pediatrician in the public sector. So progress is being made, but we know that there's an enormous amount of work to be done ensuring more equal distribution of our skilled workforce. Just one slide in the interest of time. around our allied and allied professionals who work both in the health sector, but also in other sectors, the education sector, the social sector. And I think one of the opportunities for us is that as we have more of a focus on the first 1,000 days, the importance of supporting the development of young children, we have an opportunity to include other cadres to work closely in collaboration with them. But of course, that does require coordination and agreement around task sharing and the different roles that roles and contributions that workers from different sectors can play. So I think I can skip this slide in the interest of time. So this really then starts to pick up what are some of the gaps, the strengths, and what would my list be of things that we should be thinking about as we look to the future. So I think the first one, and I made this point at the beginning, that we really need to be more active in advocating for and engaging with decision makers around human resources. Certainly from a national point of view, I don't think we engage sufficiently. Of course, decisions around human resource deployment are made at a provincial level. And whilst it's very appropriate, and in a sense, it's a strength of maternal and child health services that we are so embedded within the overall health system, we do need to pay attention and figure out and be on top of and advocate for ensuring that maternal and child health services are receiving their fair share of the human resource investment. I think we've talked about the need for equitable distribution, stronger primary healthcare teams, investment in nursing, ensuring that community health workers do, and mid-level professionals do prioritize or at least pay attention to maternal and child health. I've talked about the need for us, there's a T missing, but to maintain and reinstate DCST positions. Minister Motsoaledi established the DCSTs, and we think that with the right advocacy, then he will come out in support of maintaining and the DCST positions, but we need to figure out how to do that. Who's going to do it? How is it going to be done, etc. And then the last 2 points, we do need to invest in nurse training, both generalist nurses, but also our pediatric and neonatal nurses. And then finally, addressing some of the training needs that I haven't really touched on in this presentation, but also to think about career pathing so that maternal and child health service provision really becomes an attractive proposition for all, for our community healthcare workers and our mid-level workers. Thank you. That brings me to the end of the presentation and back to the chairperson.
So thank you very much, Lesley. You spot on time, and I think you've covered all the key issues very well. So there has been a discussion on, I don't see any questions as yet in the Q&A, but in the chat there has been discussion. So Lesley, 2 questions for you. The first one relates to in the chat, the discussion that we have got the severe shortage of nurses, yet we continue to train. But the counter argument was raised that even if we trained at a greater level, we wouldn't fill the need. We have the other situation among doctors where young interns and community servers are struggling to get positions. So perhaps your views on this balance between continuing to train high numbers but not being able to fill these positions. How do we deal with that dilemma? Any views on that issue? Should we start reducing our training at medical schools and nursing colleges? Or we know there'll always be a need, and should we continue with that trajectory, recognizing some qualified doctors and nurses are not then filling positions? Lesley,
Yeah,
can't hear you.
yeah, Haroon, I think, shall I go ahead and answer now?
Yes, please.
Yeah, so of course that's a very tricky issue, and I think we don't have the answer to that dilemma. Certainly with nursing, we do still have high vacancy rates. So I think the issue is less acute there, and I think we do need to continue to train nurses. Of course, we do know that when we are in tough financial times and during periods of austerity, the easiest thing to do is to not fill posts. And we certainly suffered that during the previous financial year. Haroon, with regards to doctors, I think that there is an argument that we need to look at those numbers very carefully. Because there was a significant increase in the number of medical students that were trained. And there was an expectation that the health system would be able to absorb them because of more funds being available, and exactly the opposite has happened. So I wouldn't really want to comment on that. I think they're two slightly separate issues. I think there are some issues around training in general, the numbers. But I do think where there's no doubt about the argument that we should be advocating for a bigger slice of the pie in terms of maternal and child health. Yeah, let me stop there. Thanks.
One other question, Lesley, I know you need to go, and that's the issue is that we recognize with austerity, posts have been frozen or not filled widely. Do you have a sense that in decisions to reinstate posts, there's any priority given to maternal and child health, or do we have the same status? It just depends on where we're shouting the loudest.
So Haroon, I think again, I think that's something that people working at provincial level are better able to comment on. But I think that this highlights the gap that we as a community have not been addressing this issue kind of in a systematic way. So I mean, I can talk about what's happening in the National Department of Health. The posts have been unfrozen. It takes time to fill them. But my sense is that at provincial level, it is, as you say, where people are shouting loudest. And I think one needs to think a little bit about how do you stop that happening? It's not an easy issue to address. But the more coordination, the more data that one has, I think can assist with that. Thanks.
Okay, Lesley, thank you very much. Much appreciated. I know you've got this other commitment at 10:30. We've already reached the 10:30 mark. So, Lesley, thank you so much for making yourself available. I think your presentation probably highlighted a lot of key issues, and it really was useful getting an update on what the situation currently is. So much appreciated. Thank you, Lesley. All right, folks, so we're moving on. And so our next speaker is myself, and I'm going to be talking about using a competency-based approach to our training. So let me just start off my slide and then I'll comment. Okay, so I trust you can see my slide. So what I want to do today with this particular lecture is I want to propose a very practical, very hopeful idea that, in fact, we can strengthen the workforce, but how we do that is by changing how we train people. not by offering more content. And so that by offering smarter and more focus and more real-world training, we can change child health outcomes. And that approach that I want to talk about is called competency-based training. And so in this 15-minute presentation, I want to show you why it matters so deeply in the South African context. So why this moment demands a different approach. And so let me begin with the reality that everyday clinicians in South Africa face the sharp end of child health. We see very sick newborns, children with severe acute malnutrition, pneumonia, diarrhea, sepsis, trauma, chronic conditions, HIV, TB. And in many of our district facilities, and many of you have lived this, there may be just one clinician on duty. It might be a nurse in triage, it might be a community service doctor in casualty, it might be a medical officer on night call. And at those moments, when it's 2 o'clock in the morning and a child is in danger, one question matters more than any other. And that question is, can this practitioner recognize what is wrong, make good decisions, and act safely right now? And so it's not, did they pass pediatrics 3 years ago? Did they attend a block, whether a nurse or a doctor? Did they recall a list? But can they do the tasks safely, consistently, under pressure? And so competency-based training is a way of ensuring the answer is yes, not by chance, not depending on who happened to be their supervisor, but by design. And so how were most of us trained? Most of us were probably trained in the traditional way. I suppose there are some young people in our audience today. But the way most of us were trained, the traditional model was time-based. You progress because time was up. Every year you moved on if you passed. The content was very heavy. The syllabus the syllabus had to be covered, and it was exam dependent. You had 1 or 2 major tests, and if you passed the test, that was fine. And so this system, it's not necessarily a bad one. It produced many outstanding clinicians. Many in the audience are living proof of this. But they were never built to ensure that every graduate could perform the essential child health tasks needed in district hospitals, tasks that are sometimes life-saving. So what they rewarded was memory rather than judgment. It rewarded attendance at lectures rather than performance. And they reward standardization rather than readiness. And so what competency-based training does is it basically turns that whole entire logic on its head. So I'm not going to go through this particular slide. There's a lot of detail, but this basically has a chronology of what has happened over the years. So I certainly trained in the 1980s, and it was a discipline-based curriculum, lectures, labs, classes, textbooks. By the 2000s, we started seeking more active learning methods. And by 2010, we started finding that students weren't coming to lectures, we were depending on third-party resources. And as we go now, the whole flavor around the world is competency-based curriculum. And that's much more about self-regulated learning. It's about data literacy, critical thinking, ethics. And in fact, many medical schools and nursing colleges have got rid of lectures, probably medical schools. I'm not sure about nursing colleges. We talk about flipped classrooms. We talk about collaborative learning. And who knows where we're going? Because right now, what I didn't say is I've moved from being a community pediatrician to a full-time medical education. I'm responsible for the renewal of the MBBCH program at WITS. And so this has become my core issue. And we're very focused on this idea of competency-based learning, which is why I'm giving this lecture. But already I'm trying to predict what the graduate of 2030, the student who's doing second year this year, is going to be doing in 2030. And clearly the biggest issue around now is generative AI integration. But I think what I put on the slide is to show that training and learning practices change over time. Okay, so coming back then to the issue is, so what is this thing of competency-based training? What are we talking about? Let's keep it simple. A competency is the ability to perform something important. You do it safely, you do it consistently, and you do it in real-world conditions. So it's not just knowledge, it's not just skill. It's in fact a combination of all of these things. You need knowledge, you need skill, you need judgment, you need to be able to communicate, you need to work in teams, and it's all about professionalism. Okay, so let's think about this as in real terms. Think about assessing a sick child. It's not a theoretical exercise. I mean, you have to notice the respiratory rate, the chest movement, the level of alertness, the perfusion. You have to ask the right questions. You have to decide whether you have to escalate care whether it's in your competency or not. And in the end, you have to counsel the caregiver. And that is the competence. And that is what competency-based training is about. Can you do the right thing at the right time? So there are stages to learning, but effectively, this is what it means. You have, firstly, in the training or the learning, someone has had to define what are these key things that a doctor, a nurse, a clinical associate needs to know. Then you have to do the necessary skill acquisition. That's what the training program has to offer. And the whole idea of this is you have to demonstrate mastery, that you can put up a drip or you know how to assess a respiratory rate. And eventually someone says, we think you're competent. Okay, and so what competence for me in child health means is you need to recognize the child's needs, you need to decide what to do, you act, and then you communicate. And how does it differ from the traditional models? Well, there's various factors, and I'm not going to really go through this out, but the focus is different, the pacing is different, how you assess it is different, the outcomes we want is different, and the whole learner experience is different. Okay, so then I'm going to talk about two additional concepts now. The first concept is the one of entrustable professional activities. Again, like competency-based education, this has now become the buzzwords and the main idea that is being proposed internationally. It's not a new idea. It's been around for a while. Our speaker, Prof Armstrong, introduced me to this concept probably at least 10 years ago. But what is this thing called EPAs, or entrustable professional activities? And all it means simply is that you take a chunk of real clinical work that you must trust a person to do independently once they've shown that it can be done well. So you have to demonstrate that the learner can do this, and then you trust them to be able. That's it. There's nothing mysterious about it. So let me give you one example from everyday practice. So say, for example, the EPI is triaging a sick child. So basically, a junior clinician assesses 3 cases in front of you. They spot breathing difficulty, lethargy, dehydration, the IMCI danger signs. But they can do it accurately, they can do it consistently, and you trust them. That's what an EPA is all about. And so whether it's a newborn examination or a child with respiratory distress, or whether it's a counseling activity, in the end, it's the ability to trust the learner to be able to do this independently. And then the other big idea at the moment is the whole idea of workplace-based assessment. And I think what that does is what, in simple terms, is you then observe real tasks and you provide feedback to the candidate. Okay, so again, the term sounds very intimidating, but it's actually very simple. And so what the expectation is that in a clinical setting, you just watch someone doing a real task and you give them feedback. That's it. We can do this informally all the time. But what competency-based training does, it makes this a little bit more deliberate. So let me give you an example. Say a senior nurse is watching a junior nurse inserting an intravenous line. So she might give feedback saying, you stabilize the hand well, but next time the angle of the cannulus needs to be slightly lower. That's workplace-based assessment. Or maybe a registrar is giving a mother some ideas about growth faltering in her child. So the consultant listens for about 3 minutes and then says afterwards, you explained that clearly, but next time remember to show her the growth chart. It will help the explanation. That's workplace-based assessment. Okay, so how does this happen? In daily practice is the message I'm saying. This is not something extraordinary. You observe, you give feedback, and if the feedback is you didn't do it well, you try it again until you've achieved mastery. Quickly then, and I realize my time is getting short, as the facilitator, I need to control it. How does this then affect various forms of training? So let me quickly go through how this approach could transform the whole training program. So for undergraduate training, medical students, nurses, clinical associates, what competency-based training means is that the students practice real tasks early and often, as early as their first year of training. They get frequent short feedback. They're not just completing the pediatric block. They are able to do the basics, whether it's triage, newborn exam, stabilization, IMCI assessment, communication with caregivers. So imagine a third-year student examining a wheezing child. So the observer watches for 3 minutes, he or she gives feedback, the student adjusts, and the student tries again. and within weeks, the student becomes consistently competent. And so this is competency-based education in action. Moving then down to postgraduate training, in the same way, there's just the same. The colleges are now seriously looking at assessment involving not just the finest college exams in the country, but making this, again, work-based, assessment-based. And so when I sign off a registrar for neonatal resuscitation, it's because I've seen him or her do it competently in real conditions, not because the PEDS rotation ended. And so a lot of the expectations then are that we have to first set the expectations. We may want to set the WBAs or the milestones. We expect students to keep a portfolio of these different performances. So it's not just me giving feedback and it's forgotten. The students compiles a portfolio, and eventually you sign the student off as being competent based on mastery and readiness, not on time. And so it summarizes this as the process. So you have these entrustable professional activities. Some people use milestones. It sets the clear learning direction, explicit teaching assessment. Then you do these assessments, and it's not just one assessment, multiple observations. You've got the coaching feedback, you document it, and eventually you produce your evidence in a portfolio. And eventually someone, whether it's undergraduate, postgraduate, has to make a decision based on your portfolio, all the evidence. Can we say that you can progress, or that you've actually reached the end of the course with the necessary amount of competencies? Okay, and so finally, I think more important is that this is fine for pre-service training, but what about in-service training? And is it relevant in a situation that most of us find in ourselves as real-time practitioners? And I think the answer is yes, that daily as people do their work, real tasks, we should be asking people to do the practices. And I think what I often hear when I do CPD training for nurses or doctors, it's often the expectation is that I'm going to give a lecture for 30 minutes and then everyone knows what to do. And I think we need to change our day-to-day routine. That in fact 10 minutes is fine for the lecture, but the next 20 minutes should ideally be whatever the lecture or the topic for discussion is, again, making it competency-based. And so whether it's ETAT or SAM or oxygen fluids, communication skills, you can apply exactly the same principles in the in-service training. Hopefully it's more impactful and more sustainable than any lecture-based workshop. Okay, so the next question is that, are we going to start off afresh? And we're not starting from zero. South Africa does use competency principles. And so whether it's IMCI, ETAT, a lot of the things, we actually are currently using competence-based. So we're not starting from zero. Is there evidence that this kind of approach improves performance? And yes, there is in child health examples. So ETAT, for example, which is, as you people know, emergency management of children. Many African countries have shown a reduction in deaths by 30 or 45% where they've used ETAT. And same thing with IMCI. There's good evidence that you get better case management, again, using a competency-based approach. So I've reached the end of my time, but let me just offer you some breaking news. Just 2 days ago, and I just fortuitous, I didn't know about this, the WHO have now released a whole set of documents providing prototype competency-based curricula. So here's an example of pediatrics and child health. And I looked at the document. There was an initial presentation 2 days ago. I couldn't attend it. But I've looked at the document, and it's an excellent document. If you've got any interest in competency-based training based on this lecture, this is an excellent source to look at it. So this is a curriculum for pediatrics and child health, but there's much more. They've developed a whole set of guidelines, including competency-based curricula for nursing, community health workers, and you can see a whole range of things. So I think this is a fantastic resource. It goes through learning objectives. It goes through modules. It provides a lot of the detail that's needed, and it makes everyone's life very useful. So I think, and obviously if you want to get a Google competence-based curricula WHO, and you'll be able to get the relevant page. To finish off, these were my key messages, that competence-based training is a practical solution. We have clear competencies, you have focused training, and it results in safer care. We have to observe to say someone is competent, but any facility can start tomorrow. And we're not starting from zero, we have strong foundations. So there goes the bell, and my last one is my vision. And so my vision is that if we do this, right, if every child is met by someone who knows what to do and can do it, then I think we're genuinely moving from crisis mode to solution mode, one competent practitioner at a time. And I thank you. All right, folks, so I don't think we've got time for questions because we do have Professor Armstrong, and he needs his 20 minutes, and we have a session immediately after this. So I'll look at the comments in the chat and perhaps respond to them. But I'd like now to move on immediately to the next presentation and perhaps introduce our guest speaker. And we're doing things a little bit different in the child health priorities. We've actually got an international speaker. As it happens, Prof Armstrong is based currently in Vancouver in Canada. So if you look at the time, it's just past midnight there. But he very graciously agreed when we sent the invitation that he says he needs his deep sleep, but he'll sacrifice it for our session. So we're deeply grateful, Bob. Let me tell you very briefly about Prof Armstrong. He's an emeritus professor at the Aga Khan University in, he set up the original university up in East Africa. But he's also been based at the University of British Columbia in Canada. He's a recognized leader in pediatrics. Many of the people on the call who's done the IPALA course, he's one of the founders of the IPALA as well. And he's also a recognized expert in global health. His particular interest is in developmental pediatrics, and his focus has been on child disability and healthy development. Bob, much appreciated. And we look forward to you to giving us this global picture, and hopefully we'll be then able to discuss how we apply it to South Africa. Please go ahead.
Great. Thank you, Haroon. And I know that I was competent to resuscitate a baby at 1 o'clock in the morning, but I was never trained to give a talk at 1 o'clock in the morning. So I hope I can get through this okay. So yeah, I would like to in some ways back up a little bit and talk about how we frame workforce. And this discussion came out of the creation of IPALA a number of years ago that Haroon mentioned. And we asked the question, does the global community of academics have a role to play in impacting child health at country level? And there was a good argument that that is the case. And we identified 4 areas where there was opportunity to collaborate across boundaries around leadership, education, research, and workforce. And interestingly, just as Haroon mentioned at the beginning, and as Professor Bamford mentioned, very few people are interested in workforce, and none of us feel competent in the field of workforce, even though we all know it's important. And so the question is, how do we structure a country to provide focus and sustained focus on an integrated model of workforce? And so what I'm presenting is just a suggestion, a proposal, but to suggest that a national child health care workforce framework is the essential element that is needed to provide sustained impact in this area. And so that's the first argument. I hope you all agree that workforce is important. Second was to suggest to you a national framework as a model, and to reflect on how this could be built over time within any given country. And then thirdly, to appreciate whether we can learn from each other across geographic boundaries. And of course, if there's anybody on the webinar this morning that's interested in workforce issues and advancing the idea of child health workforce, we have a structure within IPALA where you could actually join us and help move this field along. So that's the goals of what I'd like to do in the next few minutes. When we began doing this, we said, well, let's take a global perspective and say, where are the pediatricians in the world? And with the Paediatric Society and the Harvard-Boston group and ourselves, we did a survey of pediatricians in the world. And as you can see, the distribution is broad, and it doesn't really tell us very much. It doesn't really tell us very much because it doesn't tell us how those pediatricians are functioning, what the environment of function is in each of those countries. And so knowing the number of pediatricians isn't all that helpful. It's a publication, but that's probably the limit of the value. We did the same thing with training programs. And again, wide distribution of number of training programs, but no understanding of how that relates to the care that is being provided and the outcomes of care. So interesting, useful, but really the focus needs to be at the country level. And global information provides us with a little bit of information, a little bit of knowledge, but really doesn't get at the fundamentals. So this is the model that...
you for a moment?
Yes.
I think there's a comment that people would want to see your slides in slideshow, if that's possible. I didn't realize that it was...
I'm sorry. I didn't realize it wasn't in slideshow. Yes, I apologize. Is that better?
Much better. Thank you so much.
Okay, so thanks for interrupting. This is sort of four major components to this structure, which I think any country needs to have in place if it's to make significant progress, and it can be done over time. First of all, countries differ in the way their governance structure for healthcare. And some are governed at a national level, and I think South Africa, as in Canada, most of the healthcare delivery governance is done at the provincial level. So first understanding the internal governance of a country. And then the key issue is to establish a National Child Health Workforce Council. This is a senior council that would have federal, regional representatives, national professional bodies, university heads of relevant units, and public interest groups. So a sustainable council that oversees the work of child health workforce. So the functions of that council are shown there: set national pediatric workforce standards and competencies. We still do this in a variety of ways, but now focus it within the workforce body. To coordinate data infrastructure, to align education programs. Some of this was discussed earlier. Education program seats to the projected needs, and public accountability through annual reporting, and a national repository of innovations and models of care. We do this outside of the concept of workforce in many places, but the idea is to integrate this into workforce planning. So that's the first step: establish a National Child Health Workforce Council. This may be provincial in some cases, but would roll up nationally, presumably. The second component is a national integrated data and forecasting platform. So this is the data source, drawing on existing systems and obviously driving data systems, system development, because those systems may not be present. But the components of those systems, some of them are certainly present in most countries. Child health care workforce registry. So we heard a lot from Professor Bamford about the health professionals, but is there an actual registry, a live registry that is integrated into these other components? Obviously, population and disease burden integration, linked systems of public and population health, the training pipeline data, who's training in universities and colleges, and what does that pipeline look like, and how do you capture that data? health system metrics, and scenario-based workforce planning tools. What are the ways in which you can project workforce using innovation tools? And obviously artificial intelligence is going to bring some sophistication to that. So those are the components of a national integrated data and forecasting platform. That platform has to have the expertise to be able to develop and capture and integrate data across those various components. Third one is an academic integration. So a national child health HR research consortium. So this is a group that bridges research to policy, creating a national consortium that links universities, research institutes, and health systems. So where is the expertise around workforce, and how can you bring it together into a consortium that focuses on child health or possibly maternal child health? And so this consortium would be able to do workforce modeling and health human resource economics. It could look at innovating and evaluating new models of care, knowledge translation functions linking to ministries and national organizations, and developing a national evidence to policy to practice cycle, and defining those priorities in the cycle priorities, and a range of impact studies. So getting the universities and research structures organized around a commitment to child health workforce. And then the final one is policy to practice integration. So a structured pathway to translate national strategy to operational implementation. The policy layer would be what we've discussed before: national standards for child health, staffing ratios, competency frameworks across professions, rural and remote strategies, planning for complex high needs areas. So a whole policy layer around the major components of child health. And then an implementation layer at the regional, what may be provincial level in South Africa, to incorporate those standards, to obviously align them to funding envelopes, biggest issue probably, and performance indicators related to those standards. So we're building practice standards into the workforce, rather than saying we're going to create standards and we hope the workforce appears or remains stable. And then the practice layer at the implementation level. And however, those clinical networks, and Dr. Bamford described several of structures in the South African context. A real-time dashboard for workforce pressures, and obviously research evaluation built into feedback loops. So workforce no longer becomes something that we have no expertise in, but the whole structure of health service delivery is built into the workforce plan, essentially. And the kind of output you would expect from this effort would include an annual National Child Health Workforce Report, the ability to forecast workforce forward, the national map of discipline service capacity, so actually being able to map where the disciplines are located and how they are functioning. The training pipeline, because universities are linked into this structure, and the ability to adjust based on forecasting. And evaluation reports on new models of care. New models of care, how care is transformed, all relies on workforce. And so that's why trying to think of it from a workforce point of view makes good sense. And then obviously public accountability. So that's the sort of outputs. The benefits of using this sort of model is it stabilizes, it provides stability and greater clarity the child health workforce, and maybe actually eventually leads to some pediatricians admitting that they actually have expertise in workforce because we've entrusted them in the field. Aligns training programs with future service needs. It improves access to subspecialties because it's built into the models. It builds national and regional coherence, provides evidence-based policy cycles so that improvements can be demonstrated. And it fosters academic policy practice collaboration. The academic communities get engaged in workforce, and we develop expertise in workforce in the child field. And obviously, overall, it supports the health system transformation and modernization. So that's the basic model. It sounds undoable, like too complex, but the reality is it can start in components and build. And probably the most important component is the idea of getting buy-in to a national workforce council, or at least a provincial workforce council, that can begin to drive some of these components. Obviously, it needs buy-in broadly. So then the question is there opportunity to learn from the global community? So I know Canada best. The one thing we all have in common is we all see the crisis. And so there's a crisis in workforce in Canada as well. Different than South Africa, obviously, but still the practitioners in the system see the crisis. We have the right national organizations. We have a national group of pediatric chairs. So all of the 17 medical schools in Canada, the chairs have an organization that works together around child health issues, mostly academics. We have a research institute within the structure of research in the country on an Institute of Human Development, Child and Youth Health. And we have a Children's Healthcare Canada that brings together all of the healthcare in Canada is public, all of the children's hospitals across Canada within the Children's Healthcare Canada. And so some of the structures are there, but there is no national governance model. There's no workforce council at a national level. As I mentioned, most of the responsibility for healthcare is provincial in Canada. In British Columbia, where I am, we probably have the best chance to creating this Child Health Workforce Council. We have a provincial health authority and 5 regions, a population of almost 6 million. And the health authorities in those regions are responsible for the population as a whole, not for the hospital. We have a single children's and women's hospital within this provincial health authority. So the research and academic and training component is easily identified. We have something called Child Health BC that sets provincial standards, focuses on marginalized populations, and has created a tiers of service model that defines what level of expertise is required at what level of the community. And then you can begin to model how you achieve those tiers of service. And in theory, we have social education and health linkable data, and in theory, an electronic health record connected provincially. So those are some of the elements that would allow us to have a better workforce plan. But again, we have no commitment to a workforce council and no structure in place to plan. And other countries, lots of opportunity from other countries to learn from. But again, I think I haven't heard of anybody that has such a framework in place in their country, and people in the audience may know. But lots to learn from the United Kingdom, from the United States, from Australia, from New Zealand, and obviously South Africa. It's clear that we can learn from each other, but the focus needs to be at the country level or the sub-country level. So I think that's the that's the message I wanted to try and get across, is that human resources are key to achieving child and youth health outcomes, that we need to step back and create a model that provides a sustainable approach to workforce planning. And we need to identify countries that are beginning to move in that direction and learn from them. So I hope that hasn't taken all of my time. I'm happy to answer any questions or comments.
Thank you very much, Bob. I think I appreciate the detail of it in the course, but I must say I found the task even more intimidating than it was. I mean, I had some idea of what child workforce planning required, but in listening to this presentation and looking at what all the components are, I'm even more intimidated about whether we can do this. So I think you've highlighted that even better resource settings are not necessarily have been able to do this successfully. I suppose my question is that, looking at this big agenda, are there 2 or 3, maybe even 1 or 2 key actions that perhaps we could take on as a starting point? And are there any examples from low and middle income settings that perhaps we could look for that might offer us some ideas of what is possible? So there's 2 questions here. Is can among these various tasks, is there a starting point that we can perhaps identify in the next year or 2? And then is there examples, and even if it's high resource settings, that can perhaps give us some direction of what this involves?
Yeah, I think what the core requirement is within a country or within a region, a province, to bring together the child and youth interest, child and youth commitment to an integrated workforce plan, and to use the existing expertise, engage the existing expertise in universities. I mean, does South Africa, do the pediatric departments in South Africa meet as a department group?
Yeah, so the heads of departments meet about 2 or 3 times a year.
And do they talk about workforce?
I haven't attended those meetings, but I'd be surprised if they do.
Yeah, and yet they create the workforce. So I think it's getting some of the professional organizations involved in the country to say, if we came together and began to talk about workforce and the structure required to begin to move it forward, and where is the expertise in the universities? There is lots of expertise in universities. They don't necessarily focus on child health. But if you had an organization that came together, the hospitals in Canada, at least the pediatric chairs, the hospital chairs, and a national research institute, and those 3 groups began to frame a model like I've presented, you can begin to move the agenda forward. I think it's very hard to just say, let's pick this and do that, without having a bigger picture plan of where it's going. Because it looks so complex, but it's possible to do if you can bring the right people together.
Well, thank you very much for that. It was a stimulating talk. It certainly, the aim was to start catalyzing action on this, led by the Priorities Association. But as you've identified, I think the universities could be a useful initial partner. We have others. We have the South African Paediatric Association. We have nursing groups. But the agenda clearly needs to be addressed. But I think you've served our purposes beautifully, catalyzing and making us aware of how to perhaps view this task and identify then what our priorities are. So, Bob, I won't try and keep you up any longer. You're welcome to stay on for the next session. It's all about advocacy and the situation in South Africa, but deeply thankful for your contributions and much appreciated.
Yeah, thank you. I think I have to go to bed. I have to be up early in the morning.
Okay, then.
Thanks a lot. Thanks for the opportunity.